of these. I've been the host of these LunchBox talks for a little while now, since Martina Morris and Bob Wood both retired. And I'm going to introduce our speaker and tell you a fun fact about him. I assume your pronouns are him and Stephen, right? Okay, so Stephen is an epidemiologist at the Washington State Department of Health. He's also a PhD student at the University of Washington Department of Epidemiology, soon to be a PhD recipient. His work is currently focused on developing a deeper understanding of the relationships between HIV and other conditions that disproportionately affect marginalized populations in Washington State. And most of his research has focused on evaluating the Ryan White ADAP, that's AIDS Drug Assistance Program, and improving HIV cluster detection methodology. And we at King County are the richer for his work because we use his space-time analyses. And I asked Stephen for a fun fact. There's a few more people trickling in. I will mention that he said that he's on a personal mission to see and photograph all the species of owls in Washington State. And so far he's gotten 5 out of 18 of them. So congratulations, because those owls are hard to find. I will hand it over to you, Stephen. Thanks for coming.
Great, thank you so much, Susan, for inviting me, and thank you so much, everyone, for being here, or for being here to watch. I'll be presenting today on structural barriers to continuity of HIV care. I'm specifically looking at the impact of patient drop-off in the AIDS Drug Assistance Program. And right up front, I want to say that this is part of my dissertation work, which I'll be defending in 2 weeks. So if you love this presentation and want to see it a second time, let me know and I'll send you the link.
You muted.
Oh man, that's a bummer. Well, let's start over. So thank you everyone for being here. And thank you, Susan, for inviting me to present. I'm going to be talking about structural barriers to the continuity of HIV care. I'm going to be characterizing and evaluating the impact of patient drop-off from the AIDS Drug Assistance Program. And just to get everyone on the same page, I'll give some background on the AIDS Drug Assistance Program and the context that we're working in. So the AIDS Drug Assistance Programs are federally funded payers of last resort that provide medical services, insurance, and other services for people living with HIV who could not otherwise afford them. They pay for a lot of people's care. About a quarter of people living with HIV in Washington receive some sort of support from ADAPs, and it's even higher in Washington, about 34%. In general, people living with HIV have good health outcomes who are on ADAP. In Washington, about 90% are virally suppressed, and it's generally considered a cost-effective and important program for HIV prevention and care.
Excuse me, Stephen, are you showing slides now?
Okay, well, I didn't unmute, and now I'm showing slides, so one thing at a time. Okay, can you see the slides now?
Not yet.
How about now?
It's coming. Yes, yes now. Great, thank you.
All right, we got audio, we got visual. Let me know. Thank you for interrupting, and let me know if there's anything else I'm missing. Okay. So continuing on with background, now that everyone can see the slides. So in order to stay in ADAP, it's federally required that clients provide proof of eligibility for the program every 6 months. This is to maintain ADAP as a payer of last resort and make sure ADAP is only paying for services that can't otherwise be accessed by the client through some other means. Eligibility is based on income as a percentage of the federal poverty level. In Washington, you have to be between 138 and 425 FPL, which means for a family of one, that'd be making between $18,000 and $55,000 a year. This recertification has been identified as a barrier to care, but there really hasn't been any research further than that. HRSA hosted a request for information in 2018, where people responded with things like this. the expectation of clients recertifying every 6 months is producing barriers for people living with HIV to access care. Clients find it difficult. And things like that from really all directions, from public health departments, from people living with HIV, from service providers. But it really isn't a topic that's received any more attention than that. And then, so that was the past. And then on October 19, 2021, in the middle of this project, HRSA dropped a bombshell, and they basically said, we recognize that this recertification requirement is a problem. We're getting rid of it. So Ryan White programs now are required to do recertification in, this is a quote on the second bullet point, the frequency and manner that makes the most sense to recipient and client. So basically now ADAPs can do whatever they want to determine eligibility for clients, but there isn't really any guidance or understanding of what they should do. You know, these recertification criteria have been in place because they're supposed to keep costs down, but they're also identified as a barrier to program efficacy. And there's really, ADAPs are kind of in a position where they're being asked to make a decision or can make a decision, but have no data to support one direction or another, which is where this project comes in. So this project is divided into 3 aims because it's a dissertation project. And it basically tries to answer 3 questions. So who's being disenrolled from ADAP? Who's struggling to stay? That is, who's struggling to stay in ADAP because of the current recertification policies? We want to estimate the size of the population to describe the demographics of it. Number 2 is what happens to clients when they disenroll. So when you take some ADAP services away from someone, what happens to them? And then number 3 would be, the third part is what happens if they changed it to a 12-month schedule. So we know, we have a pretty good idea that the 6-month recertification criteria is harmful. At least that's the message coming through the grapevine. And so then what would happen if it changed? Would the cost of the program explode? Would there be too many people on ADAP? And what happens then? So I'm going to, these are the big 3 questions to answer with this project. So part 1 is, it's a characterization of the population impacted by the 6-month recertification criteria of the Ryan White HIV/AIDS program in Washington State. So these are the objectives of the first project. We want to estimate the frequency of ADAP disenrollment. We want to look at how long people are away from ADAP when they are removed from the program. And then finally, understand what populations are being affected by disenrollment. Is it everyone equally? Are there certain subgroups that are having a harder time staying on the program? So forth. So this is, I'll start by walking through the methods since this is an EPI presentation. So basically we categorize all clients enrolled in ADAP between 2017 and 2019 as either continuously enrolled, disenrolled, or enrolled ineligible. So continuously enrolled means that they're in the program the whole time from 2017 to 2019, or they joined late but successfully recertified every time. Disenrolled means they at some point did not recertify for the program in time and were removed from ADAP and lost benefits. And then ineligible means that they applied to return to the program, but they did not meet the eligibility requirements. Generally, their income was too high or too low. And just a clarification note, if they were both ineligible and disenrolled during the time period, we're going to assume they were ineligible. The idea being probably they didn't recertify a second time because they knew they were ineligible. And then so we took that and we compared the demographic and socioeconomic characteristics between those who were disenrolled and those who stayed in the program. Basically, who's more likely to disenroll across general demographic characteristics, including income and insurance and case management services. So over the 2-year period, over a quarter, so 26% of ADAP clients were removed from the program because they were unable to complete the recertification proceedings. This suggests that the recertification proceedings are a barrier that's affecting a lot of people. It's not a niche problem. It's, you know, a quarter of the people in the program are struggling with it. Maybe in other terms, more clients were disenrolled due to failure to recertify, which is again about a quarter, and were found to be ineligible. And that the median benefits disruption was 12 months. So when people were kicked out of the program, some of them came back quickly, but there's definitely the majority of them were out for a long time. And then this is going to maybe be important later, that clients who are enrolled and eligible stayed away for a much longer period of time. So when someone's income changed and they're no longer eligible for the program, they tended to stay away a long time. But the people that were kicked out because they just couldn't do the paperwork, they came back much more quickly. Here's the demographic comparison. This chart represents the risk ratio of being disenrolled from ADAP. This line in the middle is the null, and categories that are to the right of the null are going to be more likely to be disenrolled, and categories to the left of the null are less likely to be disenrolled. And I think that the most salient information here is the groups that are more likely to be disenrolled were Black people, people who are young, and people who are uninsured. So think about what those populations look like and how they're doing, what their barriers to care might be generally. But again, it's Black people, young people, and people who are uninsured are more likely to be disenrolled. So sort of all of that data together sort of paints a picture that disenrollment from ADAP is common, and that we're really more often removing people based on whether they can fill out the paperwork than based on their financial eligibility. And that the current recertification policies disproportionately impact populations with existing barriers to HIV care. So as I could have maybe coyly hinted at before, Black, young, and uninsured people living with HIV have the lowest rates of viral suppression in Washington, which suggests that they have other barriers to care, and maybe this is an additional one that they really don't need. And now we struggled for years to improve viral suppression in these populations, and I think this one is really one that's in the control of the policymakers. So this is a modifiable contributor to health disparity and should kind of be seen as an opportunity. So just sort of some limitations of this study. There's going to be some ambiguity as to whether people who aren't recertifying are struggling with the paperwork, or maybe they're just ineligible and don't want to recertify because they know they're not going to get approved anyway. And I think that's, it's hard to describe a population that just doesn't show up again, but I think there's a pretty good case that that's not what's happening here, at least for everybody. The first is that the demographics of the affected populations don't really support this. Looking at uninsured people or young people or Black people, like that's not populations that are necessarily economically very mobile and are probably, these aren't the populations you expect to have income increasing and becoming ineligible for the program. And the other point to that is that people who are ineligible tend to stay away from the program for a long time. And that's pretty distinct from people who are disenrolled that came back very quickly. All that's to say that it seems like there's a real population of people who are for whom disenrollment is a barrier to care and the recertification is a barrier to care. And that it's not really just people who are declining to recertify. Okay. So that's part one, I think, which points to disenrollment being common. It's not just something that happens sometimes. And the next question is, what happens to people when they disenroll? So the objective of this aim is to compare the risk of viral suppression between those who disenroll in ADAP compared to those who are continuously enrolled. So basically, what happens to viral suppression when someone falls off the program? We want to compare it by coinsurance type. Is it different if you're uninsured than if you have private insurance or public insurance? And then finally, we want to explore how much of this is attributable to confounding. So is it truly a barrier to care, or is it just, some people have trouble with paperwork and also have trouble with navigating medical systems, and it's not really the disenrollment itself that's a problem. So all those questions to be answered. So walking through the methods, the same population as part one. So it's people in ADAP between 2017 and 2019. And we compared viral suppression before and after their recertification opportunity. We use HIV surveillance data and definitions for all the pros and cons those present. And just briefly that we use 200 copies per milliliter as a cutoff for viral suppression, and we expect people to be tested every 12 months. And if not, we are considering them not to be virally suppressed. And we looked at one time period per client. So basically we're looking for people who are disenrolled or ineligible. We see what happens the first time they left the program. And for people who are in the program the whole time, we looked at what happens during their first recertification opportunity. I hope this isn't too technical, but it's quick anyway. We used a Poisson generalized linear model to model the risk difference in viral suppression. We adjusted it for age, sex, race, transmission category, region, insurance type, and case management usage, just to hold those things equal between groups. And then we did an additional model to look at interaction by insurance type. And then those results, I think, can stand on their own. But there is the sort of residual question of, is this effect just from, you know, when if we were to see people lose viral suppression when they drop out of ADAP, there's potential it could be confounded by other barriers to care. The people who drop out of ADAP may be more likely to be homeless, they may be more likely to use illegal substances, have poor mental health or heavy drinking. We want to be able to account for that to understand how those might affect our estimates of effect. Now, unlike those other variables, we don't have the ability to measure it for the entire population, but we do have those values for a sample of people gathered for the medical monitoring project, which makes this a nice opportunity to use a technique called quantitative bias analysis, where from the parameters we derive from the medical monitoring project, we can sort of develop a corrected estimate to look at what would happen if these barriers to care were imbalanced between groups. So just sort of to give a roadmap of our analysis, the first thing we're doing is looking at traditionally adjusted data. So we're looking at the association between ADAP disenrollment and viral suppression, adjusted for these variables up here. And then we're going to take that association and adjust it further using quantitative bias analysis. So we have these additional variables that we can't measure directly on our population, but we can measure this association, which is the risk difference between these and viral suppression using MMP data. And we can also look at the prevalence of these confounders by disenrollment status. And sort of, well, you'll see the results of that in a minute. So this is the traditional adjustment. We can start on really the first row. So looking at the entire population, we look at those who are disenrolled. 83% were virally suppressed before they're disenrolled. Only 69% were virally suppressed after they disenrolled, which represents a adjusted risk difference of 12%, which means that out of 100 people who are disenrolled from ADAP, an additional 12% lose viral suppression when they're removed from the program, which is pretty large relative to other disparities we see in Washington State. It varies a little bit by insurance status. People who are uninsured are right at that 12% mark. People who are privately insured fare a little better, and only the adjusted rate difference is 8%. And then the biggest effects are among people who are dual Medicare and Medicaid, which is 22%, and those people are necessarily disabled. So it might be a population at higher risk towards losing viral suppression, and then other public insurance also has a pretty significant drop. Of note, people who are removed from the program because they're ineligible, they still a fairly sizable portion of them lose viral suppression, but it's not nearly as large as those who are just removed from the program because they failed to recertify. I promise this is the ugliest slide you'll see in the presentation, but this is sort of setting the stage for the quantitative bias analysis. These are our different confounders that we looked at. Parameter 1 would be the relationship between them and viral suppression, and that's in the second column. And then parameters 2, we have the prevalence of confounders by disenrollment status. So this is the prevalence of the confounders in people who are enrolled in ADAP, which we can get from MMP. And then we'll be estimating different variables for what the prevalence of those confounders would be among people who disenroll. And this is what these results look like. So to sort of walk through this, basically on the y-axis is that corrected risk difference. We saw it was 12% for the entire population without any adjustment, and that's represented right here. And that's if the prevalence of those confounders, homelessness, substance abuse, mental health, were the same between people who disenroll and people who don't disenroll. On the x-axis, we vary that assumption. So what if people who disenroll are more likely to be homeless and more likely to have mental health issues and more likely to have substance abuse? In that case, our observed risk difference starts to decrease. And we can see that, you know, the more that these confounders exist in the population that disenrolls, the lower the amount of the risk difference we can associate with disenrollment. Of note that you can't turn this the x-axis dial high enough to really explain the whole effect. You get up to around prevalence ratio of 2, and you're talking like, you know, pretty close to the whole population is homeless and a high portion of the population is using injection drugs, and you're really getting beyond the realm of like reasonability. And at that point, you still see an effect of disenrollment. So all of this is to say that you really can't explain the risk differences we see just from differences in these variables. So for bringing all this information home, basically people lose viral suppression when they are removed from ADAP. That we can't attribute this to differences in demographics. And this shouldn't be surprising. You know, ADAP is supposed to be a payer of last resort. We're only supposed to be paying for care for people who can't otherwise obtain it. And so it should be no surprise if we make it hard for people to stay in ADAP and they fall off, that their HIV outcomes aren't going to be great. Just getting back to limitations, there's certainly potential for residual confounding. We did that quantitative bias analysis to try to account for what we could. We can't account for anything, although we can say it would probably have to be a strong confounder to explain the rest of the association we saw. And this might be a little technical, but I imagine it's on some of your minds, that there's potential for misclassification of people who leave the state. So if someone leaves Washington, they're not going to be re-enrolling for ADAP. And they're also going, maybe because of the surveillance definition, are going to look like they're not getting viral load tests and they're not virally suppressed. So there's some potential for misclassification if people leave the state and look like they've lost viral suppression, but they really have just, you know, are getting care somewhere else. That is certainly potentially true, although we did a follow-up sensitivity analysis, and even if you exclude people who, if you include only people who are getting viral load testing in Washington and don't do any imputation of missing viral loads, that you can't explain the whole effect. We still see this drop off in viral suppression when people leave ADAP. Okay, so disenrolled ADAP is common. People lose viral suppression when they're disenrolled, which I think together could be put together into a compelling case that we should change that. Well, that policymakers should consider changing the recertification criteria to a longer time frame or something else. So this third part is looking at what would happen if there was change from a 6-month recertification criteria to a 12-month recertification criteria. Now, that didn't come out of nowhere. The 12-month recertification criteria, it's been suggested prior to this bombshell that HRSA dropped. And the reason behind it is, you know, it's pretty simple. Like if we go from 6 months to 12 months, ADAP clients are going to have half as many chances to fall off. Disenrollment presumably happened about half as often. It's been successful in Medicaid for Children and CHIP, and it found that it reduced churn and it reduced administrative costs. And it's really, you know, it's only one change you can make to the process, but it's an important option because it's fairly straightforward. You know, you can drop it right in today while we work out something better, or if it works great, then just stay with it. So that leads to the objective of the third aim, which is to assess the impact of extending the recertification timeline on the cost of the Washington ADAP program, the number of people virally suppressed in Washington, and the number of clients who receive services while ineligible for the program. So more formally, this is the analysis we're going to do. So the eligible population is adults living in Washington State who are current or former clients of ADAP. So people in the, we're in the ADAP universe. We're going to do a simulation over 5 years, and we're going to compare standard of care, which is 6-month ADAP re-enrollment, to a 12-month ADAP re-enrollment. And we're going to compare things like administrative costs, program services, costs, and health state distribution. And the tool we're going to use to do this is a Markov model. So it's basically a simulation of the population in ADAP and what would happen in different situations. So people can occupy any of these boxes and transfer wherever there are arrows. So basically people can come into ADAP, and people do that at a consistent rate. And once they're in ADAP, they can either stay in ADAP, they can stay in ADAP, they can be disenrolled because they fail to recertify, or they can become ineligible and then are removed from the program because they're ineligible. And that's just sort of like a toy model of what could happen to someone who's in ADAP. This is sort of the trajectory of the project. That was the structure of our model. And the first step would be derive parameters from the Ryan White and HIV surveillance data, so that we know how many people are in each of these boxes and how they transfer between them. Next, we want to make sure our model is actually giving us results that we can believe, and that process is validating the model against the 2017 to 2019 historical data. So basically, we feed the model and then see what it comes out with. But in 2017 to 2019, we have the data to be able to tell if the model is giving us realistic results. If it passes that test, then we can project it forward and look at, let's see what this model would do between 2021 and 2026. We can compare it between a 6-month recertification schedule and a 12-month recertification schedule. So these are the things that we'd be interested in such a comparison. We'd want to look at ADAP enrollment, the number of clients who are removed from the program costs, the program cost per client, and the number of people virally suppressed. All right, here's where we get to some cool pictures. Well, I think they're cool. So this is the result of the validation. Each of these charts represents a different population. So the top left is the population that is enrolled in ADAP. And you can see the dark black line is what actually happened in Washington. And the dotted line is what our model sort of projects happened during this time period. And this time period is 2017 to 2020. So you can see that for people enrolled in ADAP, it did a pretty good job of simulating what happened over that time period. And it's not too impressive, it's just a linear growth, but that's what happened. The number of people disenrolled, similarly. And then finally, the number of people ineligible was close, but a little bit, our model was a little bit different from reality. And what we saw in this time period is there was sort of the beginning of an exponential increase in the number of people who are enrolled ineligible from the program. And frankly, we just didn't believe this. We think this was probably an aberration that, if you look in as things go forward, you probably wouldn't expect this to keep growing up and up and up, because then ADAP would be empty. So we sort of simplified it a little bit and kind of stuck to this trend, which we think is probably more realistic. Okay, so we passed check 2. We feel like our model is giving us the results that we'd expect. And so now we have to figure out what it means to have a 12-month recertification schedule. And what we landed on is that if we're going to implement a 12-month recertification schedule, no one would be enrolled for the first 6 months. Sorry, no one would be disenrolled. Basically, everyone gets an extra 6 months of eligibility because now they're on the 12-month schedule. And then for our parameters, we'd have clients drop off half as often because they're only being checked half as often. Clients who are ineligible would then remain in the program for another 6 months because we're not checking as often again. But then after that, we would check and they would be removed from the program. And then also we'd have to modify the costs a little bit. If people aren't recertifying as often, costs associated with recertification would go down, which would be basically the time that ADAP staff spend collecting and going through paperwork, and also the time that case managers spend helping their clients recertify. So here's what the program looks like for the next 5 years. The solid line is as things are, a 6-month recertification criteria. And you can see the ADAP enrollment continues over time. And the dotted line is what would happen if we did switch to a 12-month recertification criteria. You can see at the first 6 months, when I said everyone has that extended eligibility, enrollment goes up quite a bit. And then it's sort of more or less, it's not quite parallel, but is much more closely aligned with the 6-month recertification criteria trajectory. For disenrollment, the same thing happens. With the first 6 months, no one disenrolled, so that sort of category gets depleted. And then you can see that disenrollment continues to grow a little bit, but not nearly as fast as if under the 6-month recertification criteria. And eligibility is somewhat similar. You can see that they're not as dramatic an effect on the ineligible population as the other two. In table form, here's kind of how it looks over the next 5 years. That with the current requirements, we have about 4,700 people in the program. If we switch to 12-month recertification, we get up to about 5,300. We have about an average of 200 clients in the program at the time who wouldn't have been there otherwise, or sorry, who are ineligible and shouldn't be. The number of clients dropped and ruled ineligible go down quite a bit, as you'd expect. And then here are the costs. The 6-month recertification criteria is intended as a cost control measure. And so this is what happened if it was removed. Basically, the total annual cost would go up 7%. We'd save a bunch of money on recertification staff and case management time because those people aren't spending time helping clients do that. But the cost of services would go up a little bit. Well, 12%. It's not just a little bit. That being said, the cost per client would go down about 5%. So the program would be more efficient in that respect. And most importantly, the number of people virally suppressed in this population would go up about 250 people. So sort of bring that together, a 12-month recertification schedule would yield a more efficient ADAP program with lower administrative costs and a larger population served. This is the big takeaway to me, is that 245 fewer unsuppressed people living with HIV represents about 10% of the viremic people in the state. So this potentially could, really change the course of the epidemic in Washington. It's not an insignificant number of people. The model does have limitations, as always. It doesn't encompass health impacts other than viral suppression. Giving people medical care and dental care and mental health services is a good thing, and it's not to be overlooked. And also reducing the number of people who are not virally suppressed reduces transmission in the state, and we didn't really investigate the effect of that. On the other hand, the model assumes that everyone who's disenrolled wants to come back. That's probably not the case. At some point, if you let every disenrolled person who wants to come back, some of them are out of the state or aren't interested in ADAP anymore. So the model might be a little optimistic in that regard. Okay, so now is the time for me to get on my soapbox and pretend like someone's twisting my arm to answer the question, what does these results mean for other ADAP programs? So all these results are in Washington, but Washington's only one of 59 ADAP programs, and different ADAPs are different. I think everyone I've talked to who works with ADAPs loves to say that if you are an expert in one ADAP, you know about one ADAP, and there's very little that can be said about other programs. That being said, they all have this, there is some similarities between them, and I think we can say some things about other ADAP programs. They all have the same minimum recertification requirements, or at least they do for now, now that they have the freedom to change things, that's gonna start to change. But we can say for the data we have that Washington makes recertification easier than some states. So I wouldn't expect to see disenrollment be a bigger problem in Washington than elsewhere. Disenrollment, likely a large number of people are disenrolling in every state. That being said, that doesn't speak to the effect of being disenrolled. And that's going to depend on the services that clients use in other states and what they have access to inside and outside the program. And to that point, we can say that people in Washington are in ADAP for many reasons. The populations serve their ADAP serve their populations with the best they can with the funds they have available, and that some states can only pay for direct HIV care. In contrast, Washington offers a lot more. We do things like insurance premium, outpatient medical care, substance abuse treatment. All that is to say that people who are on ADAP in Washington may have access to ART from other places. If you're in a jurisdiction where ADAP only pays for ART, that means everyone on ADAP needs ADAP for ART. So I think that speaks to the idea that in other states, people might do worse when they leave ADAP because they really might be using ADAP just for antiretroviral therapy rather than people in Washington where some of them might be only in ADAP because they want to get dental care. And to that point, this is a graph of the annual cost per client served by ADAP program. Washington is this golden bar here, and you can see it's sort of on the lower end of the distribution. So ADAP is probably serving in other states is spending more money on clients, and they may suffer more when they're moved from ADAP. Secondly, the population served in Washington may have higher income than others. Washington is one of 39 Medicaid expansion states, which basically means that the people in ADAP have higher incomes than in other states where it isn't Medicaid expansion. So that getting removed from ADAP in Washington may be less disruptive to this population than the population in other states where Medicaid covers a smaller proportion. And that's to say that if you're not in a Medicaid expansion state, ADAP is filling more crucial gaps than maybe it is in Washington. So to sort of bring it all together, that Washington and other ADAPs should strongly consider moving to a 12-month recertification schedule or longer. I wouldn't be opposed to that. That being said, changing the frequency of the recertification doesn't address the root of the issue. The root of the issue is that people are having trouble with this recertification process, and it's difficult for them. You can change how often it happens, but that doesn't really fix it. And I think that further research would be helpful to sort of understand where the barriers are and where it can be improved. And ideally moving towards something like an automated eligibility where the clients don't have to do anything. And then finally, I think it sort of opens maybe, at least in my mind, a broader conversation of what we gain from removing people from this program. You know, people who fail to recertify lose viral suppression when they leave the program. But also people who, even who are ineligible, lose viral suppression when they leave the program. And maybe that, you know, HRSA, I think, is starting to think more broadly about this question. And I think it's something that needs to be considered, that maybe kicking people off the program isn't really what we're in the business of doing. All right, well, that's all my presentation. Thank you guys all for being such a wonderful audience. And I'd love to answer any questions if you have any. I see, Raina, you have your hand up.
Thanks, Steve. Honestly, what a brilliant body of work. I'm so excited for what you're doing. Can people hear me okay? I'm getting a feedback.
Yes.
Okay, great. Yeah, I think my question was part provocative, part philosophical. Why? And so I take your point, all ADAPs are different. So maybe we focus on Washington State. Why does Washington State ADAP even require recertification? So I understand, right? Like people, the state will want to save when people become ineligible. Either they move to Medicaid, that block, or they go down to some other higher level of insurance coverage. But the vast majority, it seems like, Stephen, are going to stay in ADAP because of, you know, the structural social reasons why they're in ADAP in the first place. So why do we even ask clients or patients to recertify? And is that something you can model getting rid of? I mean, you've done it a little bit by changing it from 6 to 12-month timeframe, but right, as a thought exercise, what if we remove recertification altogether?
Yeah, no, I think that's a really good question. And I mean, the cop-out answer is that we have to. The federal government requires us to. But I think that the theoretical backing is that, there's only so much money we can spend on ADAP. And I think it's a balance of, making sure that we get a minimum number of services to the population that really needs it, versus being able to expand our services to be able to offer a wider range of things. And so I think that if we were to let everyone on ADAP, we might end up not having the money to serve the population that really needs the help. And I don't think that the current income eligibility and the recertification criteria is a particularly effective way to do that. And yeah, I think it would be absolutely worth investigating what would happen if we never kicked anyone out at all. And I think, it might be okay to put the ball in the client's court and say that this is the payer of last resort, and use your other insurance first.
Can I add something to that, Stephen?
Please.
Some of the work that you do around rebates and forecasting the rebates, because rebate dollars are generated from what we basically spend in ADAP, would actually bolster the reason that because we are never, okay, Washington State, we have more money than we have spending authority to spend in a year. So when you ask the question about why do we do it, it's strictly, and for those of you who don't know, I'm the PI on the Ryan White grant. So the money that funds ADAP, it's under my purview. Although Martha and Beth do the ADAP, the money piece is kind of what I report to our project officer, is there is no fiscal reason for us to do it. But up until we saw this last HRSA kind of bombshell, like they're rethinking it, it's always been in the scarcity mentality. And I have to admit, I don't understand enough about the financial implications in the non-Medicaid expansion states to make any universal kind of pieces. But in Medicaid expansion, I really don't, it seems like an antiquated notion.
I agree. Thank you, Lydia.
I have a technical question, Stephen, and that's in your first part, you didn't talk about, I don't think you did, sorry if I missed it, HIV risk categories, like MSM and people who inject. You got into some of that in your second part, matching to MMP. So I was wondering if you looked at disenrollment by people who injected drugs as their HIV risk specifically.
Yeah, that's a great question. Thank you, Susan. Yes, we did look at it. We didn't see a huge difference, which was a little bit surprising to us. People who inject drugs were more likely to disenroll, but it wasn't statistically significant, which it could also be a sample size thing too.
Interesting. If I'm not cutting anybody else off, let me just also follow up with, when you matched to MMP, or you looked at MMP to help train your model, do you have a rough idea of how many of the ADAP enrollees had an MMP interview?
Yeah, so it's spawned a whole list of follow-up questions, but about half of MMP participants were on ADAP, which is interesting because it is actually MMP overrepresents the population enrolled in ADAP, which has maybe some implications for MMP as a whole, but was convenient for this project.
So if about half of the MMP participants are on ADAP, and there's roughly 200 a year who get interviewed, and if you looked at 2 or 3 years worth?
Yeah, we looked at 4 years, so it's about 400 individuals in MMP who were included. And that was probably about 8 to 10% of our study population.
That's where I was going. That's a fairly robust number. That's good.
Yeah, MMP people do good work.
So does anyone else have any questions? I think that Julie Dombrowski posted a link to your upcoming dissertation. So I'll let people, remind people who aren't in the chat that that's there, or feel free to email one of us if you'd like that link, and we'll just give you a virtual round of applause and thank you. Julie, I see you came on video. Do you have anything to add?
No, you did a great job, Stephen. That was fantastic.
Oh, thank you so much. And yeah, as Susan said, if you want an encore presentation, come to my dissertation defense in a couple of weeks. It'll be even bigger and better.
Thank you. And thanks everyone for attending. And I never remember to look to see what's upcoming in our Lunchbox series, but something will be coming in a couple months, and hope to see you all there and then.
Thanks, everybody.
Bye, everyone.